as far as content goes, we'll put some content together. So we're going to go, you need to understand blood. Blood plays a big factor in cancer, and it plays a big factor in the liver. Okay? So we're going to look at the components of blood, and we're going to talk about some things with that this morning. You will not have a homework assignment for me for Monday because your assignment was what I just gave you. Okay, I know you had an assignment for Dr. Sayer today, right, that you turned in. You will not have one for me Monday because your assignment was actually your presentation today. Okay, because your exam was on Monday, right? Again, thanks, Miss Hackney.
What did we turn in today?
It's,
Hesse.
I tried to incorporate different things other than just putting an assignment on there, okay?
Yeah, I was kind of confused.
So,
I didn't do anything for Sarah.
The assignment for Sayer was the Hesse question. Yeah. Well, I was confused too. I was like, what?
Yeah.
Sorry, we're all not there.
Well, okay. Get you a calendar and start writing down what you have to do because it's very important that you know what you have to do. She likes to assign them from Evolve. I prefer hands-on assignments. Miss Huffman will do her own assignments, okay? Everybody will give you an assignment due every week, okay? I'm not giving you one for Monday because you did mine for this week, okay? My lecture content, you already did an assignment for that. That is your assignment for me for this Monday and Wednesday. I keep wanting to say Thursday. Monday and Wednesday, this is your assignment, okay? Anybody who has Dr. Sayer in the morning, we will be here at 8:30 in the morning for simulation. Okay? She wanted me to make that announcement for you all. 8:30, Sims Lab, if you're with Dr. Sayer. Me, PCCU, at Memorial. You will meet me at 6:45, between 6:30 and 6:45, in Memorial's waiting area, the bottom entrance as you go into the hospital. We do not have tomorrow morning. Between 6:30 to 6:45, you're running a few minutes late, send me a text. It's not a big deal. It's our first day there. We need to get oriented to the floor and things like that, okay? Peaks was kind of a flop this week. There was probably only 2 babies that they could even go in and see. PICU only had 2 kids, nothing going on. Everybody sat around all day. It was nothing. It has not been like that, and I'm going to knock on some wood in a long time. But it was like that on our first day of PEDS clinical. So they have alternate assignments to complete, and that will also take them from your 1 hour for the math test on Wednesday, because I let them out a little bit early because there was just nothing else to do. I mean, there was nothing to do. Okay? So you all have already got your accredited 1 hour for the math test on Wednesday. Okay? The PEDS clinical on Thursday. You already got it. For Dr. Sayer? No. I said 6:30, 6:45. A Memorial waiting area. Dr. Sayer is 8:30 in the morning. Anybody else need to clarify? No? Under my clinical content, there is a PCCU folder. If you look under that PCCU folder, there is what you need to bring for them. It is 8 pages. We will go over it in clinical tomorrow. I'm not saying you're going to be doing the full 8 pages in PCCU, but you will have it. It is CAMC's critical flow sheet downtime form. Okay? Critical care downtime form. That's why I want you to use critical clinical time. Okay?
Are we bringing laptops tomorrow? Or no.
Yeah, they need to bring the gloves off for me.
Okay.
Especially on PCCU. I usually have mine on Peds. If it's like that again, I mean, I usually have mine and we do alternate things. We talk about Tylenol overdose. We talk about DKA only. We talk about things that you're going to need to know in this class. So I take you to another level because we see different things in Peds. We see a lot of DKA. We see a lot of Tylenol overdose. So we work on those when it's low, like it was Thursday, and it should not. I hope it's not like that again this Thursday. Yes.
The case study that you had our group look at for the Tylenol, I can't find it.
Did you look at your maternal piece?
Yes.
There's just the one page of acetaminophen Tylenol.
Okay, it's on that chart. Okay,
Yeah,
just
on the chart.
it didn't. Okay.
Yeah.
I thought that maybe that's what it was, but
Yeah,
I wasn't for
that's
sure.
it. And it talks about your aspirin overdose.
Mhm.
It talks about all those.
Signs and
What you need to
symptoms.
look at those.
Mhm. Okay.
And we'll be looking at that stuff again. You're right. Okay. I didn't actually give you the case study for it. And if we find ourselves at a time that we don't have a lot of patients, then we can do the case study for time. Okay. All right. Clinical forms for tomorrow morning for me. PCCU. Memorial between 6:30 6:45. Full uniform. Bring your stethoscope. I'd probably bring a pair of scissors if you got them. We will be giving meds. We will be doing a lot of things on that floor. We will not be, doing a lot of this. It will be a lot of on the floor. Okay? So I suggest you be prepared. You need a drug book because you will not be pulling out your cell phone on the floor. Okay? You will not be Googling on cell phones on the floor. So if you need to bring a drug book or if you need me to bring a drug book, tell me now because you will need to know what medications you're giving tomorrow. And I have a couple in my office. I can throw one in my bag. I carry more clover than you all do. Trust me. Not a lot. Okay. Any other questions about clinicals, makeup clinicals, anything like that? Anything about the PEDS assignments I gave you on Thursday? Anything else? Good job on the presentations. You touched a lot of the topics that I will be touching on Thursday. We will go through it kind of quickly on Thursday since you actually did do some work and you did listen to each other. On that, signs and symptoms are basically the same for hepatitis. Signs and symptoms present themselves usually the same. The thing you need to remember is how they're contracted and if there's a vaccine. I'm big on kind of talking, and don't think that, you might have to take a few minutes. Can't help it. But I talk a lot, so sorry. Alright. So hemostasis, it is a multi-step process of controlled blood clotting. This results in localized blood clotting and damaged blood vessels to prevent excessive blood loss, while continuing to allow perfusion to go throughout the body. Okay. Our objectives. We're going to define and describe the concept. We're going to identify the risk factors for ineffective clotting. This can be bleeding excessively or clotting excessively. You're going to recognize when an individual has compromised clotting. And we're going to talk about nursing interventions to prevent clotting complications and to manage those problems. Okay. I will always put objectives on your PowerPoint. I don't know if some people do. I have always done it. So I asked you to look at I'm going to go back to A&P a little bit. We need to know the components of We have platelets, red blood cells, and we have plasma. All of these are made in different areas of the body, and all of them have different functions in the body, do they not? This is just a little bit of A&P review for you. See our labs down here at the bottom? These are the ones we are going to look at a lot. Liver and blood. Clotting factors. PT9R and the PTC. So we have components of blood. Plasma transports nutrients, hormones, and proteins. It's kind of yellow. If anybody's ever seen FFP given, it's kind of like a yellowish color. It is still considered a blood product, though. Okay. Red blood cells carry our oxygen throughout the body, right? White blood cells play an important role in our immune system. Platelets are the ones that form the clots to stop the bleeding. And when we refer to that, it's like a platelet plug. Like if you cut yourself, so you cut your finger, right? You bleed. Then it kind of stops bleeding because it forms that platelet clot. Okay? That's essential for blood clotting. Okay? And you have to think about high elevations, medications that cause people not to be able to clot. Okay? These plugs that plug off the they are not actually a clot themselves. They only last for a few hours until that clot actually forms. Okay? So a plug is just like it stops it and then the clot forms. Okay? We're going to go ahead and look at some of the liver because where does all of this happen? In the liver. The liver plays an important role in clotting, doesn't it? Spleen and liver. Our concepts. You can have excessive clotting or insufficient clotting. These are clotting concepts. Risk factors for impaired clotting. Age, genetics, immobility, and you're going to see a lot of smoking on these. 99% of West Virginians probably smoke. As we get older, we have decreased blood volumes. We have lower levels of plasma proteins. Our bone marrow has fewer blood cells. Our RBCs and WBCs become lower. Many of you work in the hospital, you'll get this 89-year-old lady who comes in and her hemoglobin is 8 when it's supposed to be like 12, 15, 14, right? It happens in everybody. Our levels get lower. They say our hemoglobin falls after middle age. Doesn't mean we can't function, it just means we just don't produce like we used to when we were 20. I put this on here as just your normal clotting process, intrinsic and extrinsic. Just nice to know, it's not a need to know. It's just something to kind of show you the factors. look at a thrombus and an embolus. A thrombus is actually a blood clot, and an embolus is something that detaches. It's a thrombus that detaches. Right? Where do you think they usually go? Or where can they go?
Brains.
Lungs a lot of times, brain. Okay. Important to know the difference. Arterial thrombosis versus venous thrombosis. Well, arterial is associated with increased platelets or RBCs, high cholesterol, smoking, hypertension. And venous is inflammation of the vein, stasis of blood flow. So which one do you elevate?
The Venus.
And DVTs, I've seen so many people with DVTs, and especially the COVID vaccines and everything. So they are caused by surgeries, obesity, refusal to ambulate. You know how we have those patients that don't want to ambulate, and oral contraceptives. A lot of oral contraceptives cause women. Patient had a hip replacement 3 days ago. The patient states that the right leg is swollen below the knee and is one to touch. The patient has the diagnosis of deep vein thrombosis, DVT. Which intervention is appropriate for that patient? You would always elevate them. Okay. People with DVTs, you don't want them up walking around too much either. They're kind of like you start them on a anti-coag, and then you kind of keep them stable so it doesn't break loose and cut them. Okay. So the rationale for that is the patient with a DVT elevates the extremity when sitting or lying to enhance venous return to the heart. Right? If you massage that area, it can dislodge that. If the leg is in a dependent position, then the blood return from the venous system will not be enhanced. So they're not getting enough blood back to the heart. Okay? And you never apply ice. You can cause tissue injury with that. Okay? Clotting conditions, we can have excessive clotting factors. We can have deficient anti-clotting factors. We can have polycythemia, which is an increase in RBCs. Or we can have AFib, which causes the blood to stay in the heart. AFib is like this little quiver of the heart. The mitral valve doesn't work right? So the heart just sits there and quivers, and we're going to go into cardiology, but all of it kind of fits together. So with that, it keeps the blood inside the heart. It doesn't allow it to pump effectively. Okay, so this can cause blood clots inside the heart. And a deficiency in any of these can cause PE, an MI, or a stroke. anti-clotting forces. Fibrinolysis, I can't say it. Fibrinolysis, is that fibrinolysis? It dissolves the fibrin. I can never say it. Plasmin digests the fibrin itself. Okay. Protein C and protein S increase the breakdown of clotting factors. And your antithrombin inactivates your thrombin and clotting factors. I don't test you on this to go back to like your CNS and all of that, but you do need to be aware of it. It's a nice to know, not a need to know. There's just your little picture of your anti-clotting factors. So let's talk about diagnostic tests. We're always going to do a CBC, a complete blood count, which shows your hemoglobin, right? The peripheral blood smear, the Combs test, I've seen it done a few times, but not many. And your iron. Iron plays a lot with blood, so you're always going to see iron tests done. Okay? Here we go with our PTI. You all have your lab sheet. What's your normal PT? What's your normal? So when we have people who are on cheminotherapy, do they know what chemin is? Warfarin, chemin, I call it chemin. Blood thinner. It is a blood thinner. A lot of people who have atrial fibrillation will be on chemin. A lot of people who have mitral valve replacement will be on chemin. Their INR is to be between 2 and 3. You have to keep the blood thin. Okay? So it doesn't form the clot there again. Or with mitral valve replacement, you have to make sure that the valve works properly and the blood flows through. So we keep their INR between 2 and 3. PTT and the XA, you're going to see those used with heparin. Okay? We look at those when we look at heparin, when we are giving IV heparin. The most important lab you want to look at is your PT. So we can do some, if we think they have a clotting disorder, we can do nuclear medicine is probably the one that's used the most, nuclear medicine, and then bone marrow aspiration. The bone marrow aspiration is used to identify presence of leukemia or any other malignancy. I've done a couple of bone marrow aspirations. I wouldn't say that. They're painful, but I wouldn't say they're invasive. It's just one needle stick. You'll see those done a lot with people who, well, I'll just tell you, my father had myelodysplasia. then the bones don't make the red blood cells. So they did a bone marrow aspiration on him because he was getting his blood levels from all of his blood. Chronically low. I remember one time he got 7 units of blood. So, but the chemo kills the red blood cells. It came to a point to I chose to just let him be because we were doing blood transfusions to do the chemo, which was killing the red blood cells, which was the only chemo. So I let him pass and not do that anymore. Does that make sense? Because it just, but there are disorders like that, the cancers that cause deficiencies in the bone. So, and if they're anemic, they will do bone marrow aspirations on them. And I have had some children who had to have those semi-long pieces too. So I had one, I was telling me on Thursday, I had one student who had the opportunity to help, and she refused to help. And I wish she would have came and told me. I would have sent somebody else because it is something to see when you get to do a bone marrow aspiration. It's something to see. Conditions that lead to excessive bleeding. Hemophilia. Anybody know what hemophilia is?
Is that when they when they start bleeding, they won't stop?
Yeah. What did I tell you guys in clinical Thursday? Except the boy in the bubble. You have to put them away from any risk, any they can hit their head, fall, they don't get around the legs, things like that. I mean, they have a very reduced number of platelets. I don't. You might want to remember your platelet levels. If I didn't put that on your lab sheet, you might want to incorporate that onto your lab sheet. But hemophilia, thrombocytopenia, idiopathic thrombocytopenia is one we're going to talk about more in depth. Damaged liver, cirrhosis, HEPs, all the things that we're going to talk about. Okay, liver disorders. Polycythemia vera is a slow-growing blood cancer in which the bone marrow makes too many blood cells. Patients with COPD and lung disease. They'll often have polycythemia because they try to compensate for their hypoxia. They have that increased respiration. Okay? This can lead to blood clots, enlarged spleen, and inflamed joints. ABCs. Everybody in nursing school. ABCs. You should know your ABCs and assess your ABCs. ITP, idiopathic, often starts out as a viral infection. More common in women. Platelets less than 20,000. So you're going to see easy or excessive bruising with these people. The reddish purple dot is the petechia. Usually seen on the lower legs. They will take a long time to stop bleeding if they cut themselves. They can have blood in their urine or in their stools because they're losing it, women always ask about their menstrual periods. And I know that sounds horrible to some gentlemen in here, but you have to ask that question if they are bleeding. If they're going through 20 pads or tampons a day, that's excessive bleeding. Okay. They can also have unexplained bleeding from their nose or gums. Okay, so interventions for these people. Tell me what you would do for these people. Like a boyfriend. Pull on your ball. Electric razor, soft toothbrushes, safety.
You give them vitamin K.
We'll talk about that shortly, but not for idiopathic. How much that fluid did they have? It is.
My son had it, his platelets went down to 4,000.
It's idiopathic. Usually follows a virus, but it's idiopathic. I mean, it's nobody knows why. We all had viruses, right? I mean, it just happens. Just a little thing. The nurse is providing home care instructions to the parents of a child with immune thrombocytic purpura, ITP, whose platelet count is 195. Which statement by the parents indicates that they understand the instructions? Select all that apply. That would be kind of hard in a kid, right? I like the fall and everything, but I do know. I mean, the things we talked about, the extra soft toothbrush, monitor them for signs of bleeding, don't give them aspirin. Any NSAIDs, ibuprofen, anything like that would be destructive. Tylenol is the only thing we give for children. Hemophilia. We don't see much of this anymore. Miss Chandler actually works in a hemophilia clinic. And she's seen quite a bit. I honestly can't say that. It is an inherited blood disorder. There is no cure. You have to avoid any injuries or any medications that promote bleeding. They have to have good nutrition, good dental hygiene, soft toothbrushes. They'll get IV administration of their deficient clotting factor. okay, depending on which clotting factor it is. Factor 8. They can have an intracranial hemorrhage, prolonged nosebleeds. They can bruise easily. They'll have warm, painful joints, swollen joints. And these guys can hemorrhage, GI hemorrhage. Okay?
You said it's less prevalent. Is that,
Less prevalent.
well, you said you don't see it very often.
I haven't seen it, personally.
Do you think it's less prevalent or just you haven't seen it?
I think, I mean, I haven't seen it, but I mean, it's an inherited disorder, okay? It's like our class talked about before. People who carry it will still have kids.
It's recessive though,
Yeah.
so it's mostly common in like incest situations.
But we talked about that before about why do these people still continue to have children, you know what I mean, if they are hemophilia. So they hope for the chance that they don't pass it on. Okay. But education is probably the biggest thing in these hemophilia clinics. Is education. Education.
So there are chances that you would pass it on.
Yeah.
Can you know? I mean, when would you discover? I guess it's how would you discover? Let's say it's recessive and you don't have the problem, but maybe you carry the gene. I guess. How often would you go and get a genetic test?
There's not no opportunity for that. That's just what I'm saying. That there's not a lot of testing for that. You don't just go and get tested for it.
Exactly.
It's not something you go and get tested for.
You just wait till you start to bleed out.
It's education. Hemophilia is not something that we see a lot of, but it is something that you need to know.
I don't think I want to pass it on to a child.
But people do.
Yeah, I just don't think I could.
Hemophilia mainly affects males. It is a type A. It is an X-linked disease. It is a recessive trait. Von Willebrand is another type of hemophilia. They'll have lower levels of factor VIII. Von Willebrand can affect females and males. It's milder than type A. It's autosomal dominant. And you have 50% chance of passing
With all the advances in science and the way they're manipulating the genes, I mean, we may come to a time where they can just take that out, or they can alter it.
on it. Maybe.
You know, it's kind of like going to a vending machine and they want this.
Take your pick. Maybe. So the blood test we would want to look for in these would be include our CBC. With these, it's the PTC. They will have longer clotting times, of course. Some facts about hemophilia. It's an inherited bleeding disorder in which the blood doesn't clot properly. Can lead to spontaneous bleeding, as we've talked about. They'll have excessive bleeding following surgeries or an injury. Our proteins, CNS, they can help to stop the clotting, but in these cases it's harder. People with hemophilia will have lower levels of either factor VIII or factor IX. severity of hemophilia that a person has is determined by the amount of factor that's in their blood test. The lower amount that factor is, that's when they can have the spontaneous bleeding and it causes severe health problems. So we'll test for factor 8, factor 9 for blood tests. And here's just a normal who doesn't have hemophilia will have 50 to 100%. Mild hemophilia is greater than 5 but less than 50. Moderate is 1 to 5. And severe hemophilia is less than 1%.
That's the factors.
Factor 8, factor 9 in the blood.
Now, you have to have both, I mean, when you test the blood, it will both, they'll both show
That's
you
factor
that.
8, factor 8. The best thing to be familiar with is, I mean, because honestly, like I said, I've not actually had a hemophilia patient, okay? But if you would ever have one come in, if you're working in the ER or you know, anything like that, or surgery or 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 anything, and you see somebody come in and, you know, they have that, just think of what you need to test for, okay? You need to test your factor 8, factor 9, you need to check the PTI on and the PTTs, okay? The PTT is used for hemophilia. This test measures how long it takes for the blood to clot for factor 8, factor 9, 11, and 12. Okay, so you want to use the PTT for when you suspect hemophilia. Again, I'm reading in your head. Clotting times will take longer with people who have hemophilia. PTT, hemophilia, PTT, clotting times take longer, right? All right. Excessive or prolonged bleeding. Systemic would be our petechia, the purplish red dots under the skin because we're bleeding right under the surface of the skin. Nosebleeds, blood in the stool and urine, or emesis. Bleeding gums, they can bleed within the joints. And again, excessive menstrual flow. Okay? Localized is at the most at an injury site. You'll bruise, it'll be red at an injury site. Bleeding at a surgical site. Or bleeding in the brain. Somebody's bleeding in the brain. What do you think you would see in that person? Bless you. Huh? It started with a headache, yes. Very much so. So a lot of times
Blurred vision.
they'll ask for something for a headache. And I had this happen at CAMC. Elderly gentleman, his was on pivotal warfarin, INR, PTINR type, okay. He had a headache, very, very bad headache. Nurse on night shift gave him morphine for a headache. What is the number one side effect from morphine?
Headache.
Headache. Why would you give morphine for a headache? So I come in the next morning, get a report on it. Oh, she gave him morphine at 5 o'clock in the morning for a headache. 9 o'clock, this guy's not waking up. I took him to CT and he had a brain bleed and So headache is the first sign. Altered level of consciousness. Be on the lookout. And don't ever give morphine for a headache.
Is that actually on his chart again?
Morphine is one that's ordered all the time for pain, but it's not something you would get for a headache. It's not something you would
I'm
get
just
for a
trying to think of justification on a chart for that.
headache. You'll see morphine used for a lot of patients for different. Morphine has a short life. The Dilaudid is 7 times stronger than morphine, so you're not going to go with Dilaudid first. You're going to go with morphine, which is milder. But still, don't. Um, I wouldn't give morphine for a headache. The number one side effect is a headache.
Was it a new nurse?
No, but she was milking. Which comes to how did you even push it? Don't ask me. I wasn't there at 5 in the morning. I didn't get there till 7. And he passed away at 9. So, don't ask me how that was even. I don't want to know. Don't. And he passed away. But you learn a lesson from that. Don't give morphine for a headache. They complain of a headache and their INRs can't hurry. Think of bleeding. Ask for a CT scan. It takes 5 minutes to do a CT of the head. It's not that hard, right?
Are LPNs not allowed to push morphine?
Huh?
Are LPNs?
No. No. Not under my watch at home, but maybe it happens in their other controls. Hemophilia occurs in about 1 out of every 5,000 male births. See how small it is? Small. Currently, there's about 20,000 males in the U.S. who are living with this disorder. Not a lot, right? Very risky change. You would ever see it, but you do need to know about it. Okay. Hemophilia A is about 4 times as common as hemophilia B. And about half of those have the most severe form of it. Hemophilia is not race specific. There is no higher in one ethnic group than another. Okay. It doesn't pick and choose which. So a father, if you look at the next slide, if he doesn't have hemophilia, she's a carrier, these are their chances. Make sense? Take you back to your gene trees, kind of, sort of.
If she's a carrier, is it, if she has brothers, is it greater chance that they will? I'm just looking at the chart where, you
The mom,
yeah,
more common in males.
right, but I mean, if she's a carrier, does that mean that her other,
She probably had some siblings.
Yeah.
Yeah.
Yeah. Many people who have or had family members with hemophilia will ask their baby boys to get tested soon after birth. There is no test until after birth, okay? About 1/3 of babies who are diagnosed with hemophilia have a V mutation, not present in their family members. In other cases, a doctor might check for hemophilia if a newborn is showing certain signs of hemophilia. To make a diagnosis, they will perform certain blood tests to see if the blood's clotting properly. they would, if it doesn't, then they'll do the clotting factor test, the XA, or the factor 8, factor 9. And then the blood test itself will show the type of hemophilia they have in the severity because of the percentages that we go back to. Less than 1% is severe, remember? Again, diagnostics. I will beat this into your head 500 million times. Okay? I will beat this into your head. And especially if you're on PCCU. It's amazing they did. What are you going to look at? PTI. You're going to see a lot of heifer drips. What do you need to look at? PTT. Okay. So, your PT, your PTT, and your INR. I do not think that CAMC uses the XA for their heparin drips. I have used that in other states. The XA factor is actually it's done in St. Mary's and Huntington too. So there are parts of West Virginia if you work around here that use the XA factor. D-dimers. What's a D-dimer for?
They run it if you're suspected of having a clot.
That's elevated, and you probably have what's that? Our fibrinectin. We always run our CBCs, our hematocrit, hemoglobin. Always look at your platelets. You can do an arteriogram on diagram to check the clots. Arteriogram. So when you send them down for an ultrasound of their veins, many of you work in the hospital now, send them down, they do an ultrasound. The best way to treat hemophilia is to replace the blood clotting factor that they're missing, right? They need good quality medical care. That's why there are hemophilia clinics to deal with this type of stuff, okay? You need to be aware of it, though. We could all of a sudden have more than we care to around. Again, you're going to be treated usually at a hemophilia treatment center. Although they're not going to have all their care done there, so if you do work in an ER or something and they come in, you're going to have to be expected to care for that child, okay, or person. Education. Education, education, education. These people require education. Primary prevention. Genetic counseling. Injury prevention. That's for excessive bleeding. Preventing clotting. Smoking cessation. Hydration. Exercise. And prevention of stasis. Are people that don't want to move, are immobile people. Some people can't move and they are immobile. So if somebody's bleeding out, you want to look at your genetics first. Do factor 8, factor 9. Injury prevention, we talked about safety, we talked about soft toothbrushes, we talked about no electric razors, no straight blade razors, right? Smoking cessation, hydration, water, exercise, and prevention of stasis. There are no screening tests that are routinely done for the general public for hemophilia. There just aren't. It's very costly, and it's just not done. Which interventions are most important for preventing bleeding in patients with bleeding disorders? Use a soft bristle toothbrush. Avoid use of aspirin. Do not use a razor, bladed razor. All the things we talked about. Over and over and over and over. Hint, hint, over, over, over. Now to talk about some medicines. I will throw meds in every topic that we do to be prepared. If you don't know your meds, you need to go back and look at them when they are related to the topic that we're going to discuss. I'm very big on pharmacology. Very big on pharmacology. So an anti-coag, Coumadin and warfarin, we talked about that earlier, right? People with AFib, people with mitral valve replacements, right? What do you need to do for someone who's on Coumadin? What lab value are you going to check? How often do you check PTI in the earliest patients? It's every week. What do they need to avoid if they're on Coumadin? What diet do they need to follow?
A lot they can eat.
Because vitamin K, right? They have to avoid vitamin K because vitamin K is our antidote for Coumadin, right? Heparin, what lab value are you going to check for before we say ATT? Antiplatelets. Everybody always calls them anti-coags too, or whatever, but they're not. Aspirin is an antiplatelet. Plavix is an antiplatelet. Before surgery, they will want you off of these for probably about 7 days, unless it is an emergency. They will stop your aspirin and Plavix about 7 days prior to doing your procedure. Okay? These are not measured by any labs. Plavix are antiplatelets, so you can look at your platelets, right? But we don't have to measure a certain body temperature. Okay? Xarelto, kind of new, right? Caliper, Xarelto, they're all becoming new. There's no Brahmin inhibitors. No, but it is dangerous. They say it's safer, but it is dangerous. Your clot busting drugs, now think about these, okay? Your clot busting drugs, thrombolytic agents. What do they all end in?
Hey.
ACE. Okay. Heparin is not a clot buster, or it doesn't. It just doesn't dissolve the clot. It doesn't break it up. These are what you would give in what type of patient do you think we give them to right away?
Probably the DVT.
How about stroke?
Um,
How about a stroke? We're not going to run to that for an EVP.
you don't bust, you don't, that's what I was wondering, because I've had some patients that are on some of these meds after they find a clot I don't know if it's on the move or how well does your body naturally can your body naturally deal with these? Can,
Blood clot?
yeah.
No.
It can. No matter what size. Okay. Yeah, I didn't know
But when I think about busting clot busting meds, I think of strokes. And it has to be given within a certain amount of
3
time.
or 4 hours.
Some of them are different. I'm not even going to go into time limit with you on these. But they have to be given within a certain amount of time as the onset of symptoms. Okay. Alright. So you learn about vitamin and warfarin, PT9R, warfarin, PTT. What?
From the lytics, give them everything.
That's going to depend on each one of them.
Individual.
Individual medications. I'm not going that in depth in it. I just want you to know that your ACEs, your ACE, ASE. Go back and think about what your ASE stands for. And it's a clot buster. Clot buster. Okay. Heparin is an anti-coag. It does not dissolve clots. It interrupts the clotting process. And it helps the body stop the size of the clot from increasing. People who have issues with DVTs, kidneys, are more likely to have them occur again. Okay? So these people more than likely will need on a blood thinner. Anybody who's neutral inflammation is going to be on a blood thinner. Okay? Heparin can be given as an injection, or it can be done in an IV pack. It is very heparin is so important, guys. And I was on a floor one time and a nurse was told to bolus. When you bolus somebody with heparin, you bolus from a little tiny valve, like we grew up in the med lab over there, right? She bolused a whole bag of heparin into a patient. Okay. Although heparin has a very short half-life, a whole bag is a lot of heparin. Okay. So when we're dealing with heparin and in the clinical setting for pieces here in the future when you're with me, if we have to bolus somebody or you when you're a nurse, if you're told to bolus, you're always going to bolus from one of those little glass vials like you grew up over in the lab. You will never bolus from your bag. Never, ever will you bolus from your bag. Okay?
Did the patient live?
Huh?
Sorry, did the patient live?
I sent him to the unit. She was a new nurse. She was a new grad. I sent her to the unit. I was charged her. Heparin is very, very short half-life though. I have sent people to the cath lab and them still be on their heparin drip. Okay? And that's fine. They'll tell you whether to stop it before you send them over, but you will keep heparin running usually. I know at CAMC, Dr. Goad and them, you can leave it on until they get to the cath lab and they'll turn it off. You know what I mean? And that's how short it is. So just remember that, heparin has a short half-life. It interrupts the clotting process. We measure with the PTT. Okay. And you bolus from a vial, not from a bag. That's one thing I can teach you. Do not bolus is receiving IV heparin, which of the following are included in the plan of care? Well, you're always going to use a pump for heparin. I can guarantee you that. Except one, I will tell you this because Miss Craze told me that people question why they have to know their heparin calculations and their gets and all that good stuff. As a traveler, I went to work at MedStar Washington Hospital Center in Washington, D.C. Okay? I worked a cardiac cath lab there. They don't use pumps. You calculate your trips. That's why it's important because if you ever plan to go somewhere else and work, not everybody uses an infusion pump. Okay? So you still need to know how to calculate a trip manually. Okay? Or say you're on a chopper or EMS and you're critical care and you don't have a pump, you don't know how to start heparin. You need to know how to count it. That's why. Okay? So, but in the hospital setting, you will always use a pump here for heparin. Never hung on anything without a pump. Okay? You would not provide them with a razor. You never mix anything with heparin. Never, ever do I ever mix anything with heparin. You're always going to assess for bleeding when they're on a heparin drip because their IVs, where they're getting the heparin through, will bleed all the way around them. I've changed their sites 3 and 4 times a day because they'll be bleeding out around that heparin IV site. Okay? You're always going to assess level of consciousness. And you're not going to provide them with a hard bristle toothbrush. We've talked about this many times today. Our heparin antidote. I would know this. Please know this. And it is derived from the sperm semen. My last class thought that was so hilarious. How did we ever find that out? I don't know. Maybe you can research it and look at it. But it is derived from the sperm semen. You will never give vitamin K on someone who's on heparin. You only use vitamin K for. Thank you. And I'll also give you some side effects from your at the bottom. Coumadin. I will be these meds in here. You'll know these when you go before for sure. Coumadin is the treatment of arterial and venous thrombosis to prevent clot formation. It's also used for heart valves, AFib. It prevents vitamin K from forming in the body. Okay. Dosage of Coumadin, oh wow, this can be very difficult. This says 5 to 10 milligrams a day. I've seen some that take 1 milligram a day. I've seen some that take 2 milligrams a day. Okay. The important thing I want you to know about this is that the half-life. Okay. Today I might give you 10 milligrams of Coumadin. Tomorrow I might give you 10 milligrams of Coumadin. On Wednesday I might check your PTIR and you might be way over. Okay. Because that 10 milligrams I gave you 2 days ago doesn't show up for a while. while for it to become therapeutic in the body. Okay. There's a lot of drug-to-drug interactions with Coumadin. You must always review your meds when they are on Coumadin. And again, it requires 2 to 7 days to reach the therapeutic level. We usually do the heparin to Coumadin bridge. They'll be on heparin in the hospital. They'll get their first dose of Coumadin. We draw PTNRs every day. We call the doctor, tell him what the PTNR is, and then he'll give me a dose based on that. Okay. Again, you use PTT for heparin, right? PTNR for Coumadin. So the PTNR is what you're measuring, not the PTT. Okay. So we will have them on heparin and bridge them into Coumadin. They'll be on heparin for a couple of days while they're getting their Coumadin. So they reach that therapy.
What would be the purpose of that? To bridge them over like that.
Because you got to keep the blood down. The Coumadin doesn't start working for 2 to 7 days.
I mean, is it because of the harshness of heparin?
They're on a heparin, you know.
Okay.
And then you're gonna put them on Coumadin. You got a patient who has they've had a microvalve replacement. They're on a heparin drip. You got to keep that blood down. Okay. So you're gonna put them on Coumadin so they can go home. They can't go home without the heparin or even injection heparin. Doesn't work. Okay. So you're gonna bridge them into Coumadin. So they're gonna be taking a Coumadin every day. Coumadin doesn't start working for 2 to 7 days. So you're going to have them on heparin usually the first 2 days of their Coumadin treatment until you get a PTNR that is suffice to be able to take them off the heparin. The heparin has to keep the blood thin until the Coumadin starts working. Okay? Usually 2, and sometimes, guys, I've seen it take up to 7 days. Okay? It's important. Your antidote for Coumadin is vitamin K. I do expect you all to have these. And once that blood is really, really thin on Coumadin, it does take a long time to get it back down. It's not something that you can just fix like in a matter of 2 hours. Okay. Heparin you can fix pretty quick. Okay. Coumadin you cannot. The half-life is so long.
So if you're in a situation where you need the antidote, should you also expect to infuse? Transfuse?
For Coumadin? No. What would you give? What? No. What would you give? You give vitamin K IV. And if they were going to surgery, what else could you give?
Like,
Fresh frozen platelets. FFP. But not necessarily blood. Alright. This is just a little thing to tell you. If their INR is 3.5 to 5, the doc's probably just going to decrease the drug, not stop it. You're not just going to stop it, okay? If their INR is 5 to 8, you'll decrease the dose again and probably give some vitamin K. This is just showing you how we just don't stop it, okay? If it's greater than 8, yeah, you're going to stop it. Because if they're greater than 8, they're probably bleeding out their stool, their nose. Okay, so we need to stop it. Give vitamin K and consider giving FFP. Okay. Trying to get you through. Okay, so what's your antidote for heparin?
Yeah.
Sulfate.
Work fast.
Yeah.
Cumin and antidote.
Vitamin
Okay.
Takes a long time to work, doesn't it?
Yeah.
Gotta keep them on bleeding precautions, right? Need to watch them. They don't need to be falling. Right?
Mhm.
You usually don't stop cumin unless the INR is greater than 8. By that point, they are really risk for bleeding risk is severe at that point. Okay? So play with the dosage on the ones above. Okay? They may just give them 1 milligram of cumin that day. But you just can't stop. You can't stop cumin without having something else to give them. Okay? This is just a little cascade pharmacotherapy. That's how that farms and your thrombin inhibitor, your Eliquis, you're going to see a lot of them over here, your Levinox, the direct and the indirect. Apixaban, I have seen it used here for people who are HIT positive at CAMC. So apixaban is another one that we use. Argatroban, Heparin, Levinox. So look at them. A lot of meds. And it tells you at your bottom your Thrivor. Again, you would use your ACEs for glucose pain, usually stroke. Okay. I know these are just diagrams for you guys, but if you really look at them, it does talk about like your factors, and then it tells you about your medicines. You know what I mean? So they are good to look at, and they are good for you to kind of just glance over so you do know some of the meds and what they do. Deficiencies in any of the anti-clotting factors, and it just lays on there. Deficiencies in any of the anti-clotting factors, PE, blood clotting the lungs, right? MI, heart attack, stroke, brain. Invasive procedures for clotting problems, phlebotomy, removal of blood, thrombectomy, removal of the thrombus from the vessel itself. They can do an arterial bypass. And filters, IVC filters. We do have a lot of patients who do have those, the IVC filters, and those filter out the clots and keep them from going back to the heart, brain, lungs. Okay. Again, these people will always be on medications. Again, pivoted. Look at green leafy vegetables such as kale, collard greens, broccoli, spinach, cabbage, and lettuce. They should not be eating that type of stuff, okay? Positioning, again, elevation of extremity for our venous. You want them in a deep movement position for arterial, and tell me why. Can anybody tell me?
If it's elevated, then it will return. And if it's dependent
You look at your when you would elevate, when you would not elevate. Venus, you elevate. real, you put them in a dependent position. Clinical management to control bleeding. Direct pressure on the site of bleeding. Ice. We have some topical agents now that we can use, like the gel foam and the fibrin foam that will start the clotting process. We're always going to replace our blood volumes. And we need to, these patients are critical at that point because they can hemorrhage and put them into shock. I'm not going to go into all of these. You got your clotting factors again. You can look over this a little bit with your long milligrams of those. But the one thing I do want to talk to you about, we will do blood transfusions if they are in a hemorrhage state. You will replace as much blood as you possibly can, and you will force it in within like 30 minutes. You will replace very quickly. If that differs in what I'm getting ready to teach you about giving blood transfusions, but in case of a severe hemorrhage, you will put the blood in very quickly. FFP, again, you hear that FFP, fresh frozen plasma. Okay? Give a lot of it if they only come in and they have to go to emergency surgery. You better get ready to hang 3 and 4 bags of it, okay? I mean, it works fastly and it's something that you can give so they can have their procedure done. What priority assessment question should the nurse ask when taking a history of a 79-year-old female who states she has fatigue, shortness of breath, and headaches? Think about it.
About any bleeding. I mean, stool, urine.
Well, you would, but first of all, look at their diet because they're anemic. Your old people don't eat as much, right? And they probably don't eat a lot of protein. They can't chew. Make sense? Start with your diet first. I can't tell you how many times I hear, well, Mama eats like a bird. She eats a little piece of bread in the morning, and that doesn't give her anything nutritious at all. Okay? So if she's tired, short of breath, and has headaches a lot because her blood's not working right, it's because she's anemic. When I look at that, I first want to look at meds. Meds was my first. Like medication is in my head so much that I want to go to meds first. But diet makes more sense. Because Mama only eats like a bird, and she drinks a cup of coffee for breakfast, and she has a piece of toast for lunch. But Mama's not getting enough nutrients to provide her with enough energy, right? And as we talked about, age, decreased white blood cells, decreased red blood cells in the beginning. See how it's fitting together? By middle age, they are probably 50% less blood volume. Okay? Age. Upon assessment, the nurse notices that the patient has bleeding gums. The patient reports increased fatigue, malaise, and chills. What is your priority nursing intervention? What? should initially review all live analysis for pan-side opinion related to the patient's report and assess the findings of fatigue, bleeding gums, and chills. You wouldn't call the healthcare provider because you don't have any information to give them, right? I mean, you got to follow your SBAR. Okay. You wouldn't give an antipyretic because we didn't have anything mentioned about a fever in there, did we? It said chills. It didn't say fever. And you don't, there's no number there. And guys, I'm trying to get you through this because listen, this is what the tests are like, aren't they, guys? Right, Whitney? Right, Robin? You need to eliminate. I didn't give you a temp in there, right? So are you going to check the temp? I mean, are you going to give them an antipyretic? No, right? You need to learn. We are now to an NCLEX stage of questioning where you need to learn to eliminate. That's why these are included in your PowerPoint. You need to look at your rationale. These are no longer straightforward questions that you're going to be getting on an exam. Understand? You've got to start thinking in class. Process of elimination. What is not right? What is right? Okay? You would always want to obtain blood cultures. You would always want to obtain blood cultures before you would put them on an antibiotic. Okay? We don't just start them on an antibiotic without drawing blood cultures to see what it's going to be. Did you need something? Oh, I don't know. Where are you supposed to be at? Oh, right here. You scared me to death. You're holding it?
We can work on
All right, so that's why these questions are in your PowerPoints in the beginning. I like to get you prepared for the type of questions you're going to have to exam. They're not trick questions. You need to read and eliminate. Okay? We've got to start getting to that point. Question 3. A patient is transitioning from IV heparin to warfarin. What laboratory finding has the nurse identified that confirms warfarin treatment is effective?
See.
I will beat that into your head. And I will beat that into your head. I promise you I will. INR is more accurate with warfarin, right? INR. When caring for a patient with a heparin drip, what labs would be the most important to check before administration?
Okay.
Heparin, PCT. I would look at my CDC with either one of them, though, honestly. I'm not going to lie to you. I mean, if I'm going to PPNR, I want to know my CDC too. And with heparin, I want to know my CDC. But it says prior to administration of heparin. So you got to read the question. Before you find heparin, you would want to look at your PCT and CDC. Okay. Now we're going to talk about blood transfusion. There are and there are many guidelines to giving blood. Okay. going to go through the process. You do need to know it. It's fair game for your test on Monday. So, review it, make sure you know it, okay? If you suspect that someone is having a reaction to your blood transfusion, the very first thing that you do is stop it. You don't call the provider, you don't grab a set of vital signs, you don't do anything, you stop it. Stop it immediately, okay? You don't flush the line, nothing. You stop it, okay? Pre-transfusion. This is before you are going to give somebody blood, okay? They have to consent to blood products. Believe you me, there are a lot of people who do not consent to blood products. And it just doesn't have to be Jehovah's Witness. Okay? There are people who do not want blood products. Okay? You need to verify the order with another RN. You are going to put in type of screen because you have to give them the type of blood that they need, right? You're going to verify the patient's identity with another RN. You are going to read from the blood label and the blood band. One reads, one verifies, the other reads, the other verifies. It is a process to give blood. It is not just something you go in and hang and you're done. Okay? So you need to check the expiration date because blood does expire. Okay? And you need to inspect it for any discoloration, gas levels, or puffiness, which means that it is not safe to give. You always wash your hands and wear your gloves. Again, hand washing, gloves. You're handling blood. To say that I've done it in every situation, no. To teach you that you should, yes. If somebody's dying and I don't have time to wash my hands and put on gloves, I'm not. I just do it. You know what I mean? It's just whatever. But if you should be washing your hands and wearing gloves when you are handling blood products. Okay? During the transfusion, and actually I hate that this is during the transfusion because you actually should do it prior education. But you're with them for the first 15 to 30 minutes. I personally stay with mine for 30 minutes. And when do you start that time? When the blood hits the vein. Not when it comes out of the bag. When it actually goes into the person. Okay? You need to assess your vital signs before you give blood. 15 minutes after the transfusion has started. I usually do mine at 15 and at 30 just to make sure. Okay? Because you're with them for those first, I say 30 minutes. I always do mine at 15 and at 30. It doesn't hurt. You can never take any vital signs. Sorry. You want them to report any unusual sensations. If they start to get chills right away, shortness of breath, hives, and itching. Women will have a reaction to blood transfusion usually by having back pain. No kidding. My lower back is killing me.
Why is that?
It just happens. It just happens. You stop the transfusion. That's a reaction to blood. It is a reaction to blood. But women will complain of low back pain. That is one thing they will complain of if they are having a reaction to blood. Low back pain. That's what I'm telling you.
The only thing I'm not seeing on
So that would be pre-transfusion.
Well, if they're running a fever, you wouldn't normally give blood, okay? It has to be an order from the physician. If they're running a fever, he can give you an order to still give the blood. In certain situations. But if they're running a fever, how are you going to tell if they're having a reaction to it because they're already running a fever? Do you understand? So if they're running a fever prior to the administration, you would need to contact the physician and ask him if he still wants the blood given. A lot of times they will say yes. You have to look for other signs and symptoms.
It's easier to do it before you go get the blood from the blood bank.
Exactly.
I assume that's included in each facility policy. Don't they have, like, what they consider high, is it any fever, even if it's low grade?
No, it's any fever. If they are running any fever, you would need to contact a physician before you would administer blood. Because fever is the number one reaction to blood. Okay? And if they're already running a fever, you can't tell. Now, some people will tell you give them Tylenol. Go ahead and give it. You understand? But you're talking about critical situations, too. You're not just talking about, when you got to give blood now, I think we don't transfuse till they're, 7?
Well, it depends on people if they don't have any blood.
Well,
So
right.
I've seen it a lot lower.
So, it depends. But I would let the physician make that call. If they're running a fever of 101, physician says transfuse. But you're going to stay with them for the first 30 minutes, and you're going to assess for other signs of reaction to that blood transfusion, which can be chills, shortness of breath, hives, itching, and in women, low back pain. A person with congestive heart failure may have shortness of breath while you're transfusing anyway. You need to know if you're a patient, you should know their history. You should know what's going on with them medically because a CHFer can already have problems breathing. So is that going to be a clear sign that they're having a reaction? No. And then after transfusion, you're probably going to give them 40 ablasives, to take the fluid out. You know what I mean? Blood administration. You always check for allergies, previous transaction reaction, if they've had one, or transfusion reaction, if they've had one. You have 30 minutes from the time you get the blood to the floor or from the blood bank to get it to the patient. It has to be started within 30 minutes. So therefore, it doesn't mean that you go down and you go to the coffee shop or you go to the gift shop and you have that blood in your hand while you're doing all this stuff, or I'm going to grab me something to eat while I'm in there. No, doesn't happen. Because anything can happen. Another thing that I will tell you to do before you transfuse blood, you need to make sure that IV's paid. And I always go ahead and hang my blood tubing, and I hang my normal saline, and I hang it at KPO like a 10 until I go down and get my blood and I can hang it, right? The checkoff is about 10 minutes. By the time you check it off with the patient's ID bank, so there's already 10 minutes before you can start it, right? Depends on where lab is, how many elevators you got to go past to get back to the floor, or if you got to climb the steps from first to fifth, okay? So you got a lot of time limitations there, I should say. So when you're ready to hang blood, what I always do is check my patient's IV, get the blood tubing, hang the normal saline, go ahead and KPO it at 10 or 20, keep the line open until I go down and get the blood and come back, right? You have 30 minutes from the time you get it from the blood bank to have it hung. Computers show that because you do the checkoffs in the system. There is a timestamp on the blood, and it has to be within 30 minutes that you start it in the computer. Okay? You never ever hang anything with blood. The only thing you will hang with blood is blood.
Normal saline.
Normal saline. You will always verify the patient's ID, check the doctor's order. Again, you're going to check the labels of the blood bag and blood bank transfusion record with another nurse. They like you to have an 18 gauge or a 20 gauge. I'm not sure that that's so anymore. You may be able to use a 22 now. I've had to use 22 before. If you can't get a line, you just can't get a line. 22 is not the best you got. You always want to check your baseline vitals. Normal saline is the only solution that we hang, and I will beat that into your head too. Normal saline is the only solution we will hang with blood. Nothing else. Nothing else. Your blood administration tubing set has a filter on it. So when you're looking for tubing, it will have a filter. Severe reactions to blood transfusions usually occur within the first 15 minutes from the time the blood goes into the vein, not from the time it leaves the vein. 15 minutes from the time it hits the vein, or within the first 50 cc's. When you start blood, you start it at a lower rate, and then increase it over time. Unit of blood has to be transfused within how long? It has to be 4 hours. Can you use the same blood tubing if you get a unit in within 2 hours? Huh? Yes, you can. You can use the blood tubing for 4 hours itself. If you've really got to transfuse quickly and you're pumping it into somebody, you can just keep hanging in the same tubing. As long as it's within 4 hours. I don't see you doing that on the floor. I see you somewhere like that, dialysis, things like that. You never warm blood. Never. Never.
When you get it from the blood bank, I'm assuming it's cold, right?
Oh, yeah.
Yeah.
Never warm it. Never put it in a warmer. Never. You'll break down the blood itself. And then you're just administering something that's of no use. You know what I mean? So never warm it. It'll be cold. We give blood transfusion to replace cells lost from trauma or surgery. We give platelets for low platelet counts. You'll see that a lot. Cancer patients. Plasma transfusions, we talk about FFP. You'll give it to replace your clotting factors in your body. Okay. White blood WBC transfusions, rarely given, but they are given to the cancer patients for who are severe neutropenia. You can give white blood cells. Reactions. Number one is fever, as we just talked about. Okay. Hemolytic, allergic, bacterial, and circulatory overload, like I just talked to you about with CHF patients. Okay. If they're CHF, they're already probably short of breath, and you're going to give them more fluid, so shortness of breath is not a reaction for them. Okay. It is not. You can expect to give Lasix, but it is not considered a true reaction for them. Okay. A little bit of comical stuff for you. Here you go. Not going to read through it all, but vital signs that can become tachycardia and tachypnea, whatever. pretty stress-free breathing. I just want to say tachy, okay? They can become tachycardic headaches. They can have headaches, chest pain. Men have a lot of chest pain that radiates. Women, low back pain. Men will have chest pain. Okay? So you want to look at all these. You'll take the blood down. You will not flush the line. You will take the blood back to the blood bank. Okay? That blood and the tubing all has to go back to the blood bank if they have a reaction to it. You do not flush the line because you don't force the blood going into the body and force them to have another reaction to it. Okay? Low back pain. Over there. Mostly frozen women. Tell me. Every woman I've ever seen have a reaction, complain of low back pain. Alright. I will have your PowerPoint posted by tomorrow night for your liver and pancreas. I'm working on those today. I do have 2 meetings, and then I'm teaching a class this evening from 4:30 to 7:30 here. So, so it will probably be tomorrow before I have the liver PowerPoint